So we're 2 minutes late, but that's okay. We are so delighted to be here at CCAR. Thank you, Rebecca Allen and John Schwartz, for having us. Yes, and at the legislature, we bang our heads against the wall all the time. Right, Representative? Exactly. Not in Congress, but you know, the state legislature we do. So I want to thank all of our panelists for being here. We have folks from the local level, we have folks on the ground who are providing services, and we have our amazing representative in the United States Congress, Joe Courtney, our legislator, Susan Johnson, and of course my co-moderator, Nancy Navarrete, our Commissioner of the Department of Mental Health and Addiction Services, and our new Deputy Commissioner of the Department of Public Health, Jody Terranova. Jody, thank you so much for coming, and Mayor DeVivo from Wyndham, thank you so much for your leadership, and we really appreciate all that CCAR does. I've had the pleasure of visiting your facilities far and wide in Connecticut, particularly in Hartford. Governor and I really appreciate what you do. So Rebecca Allen and John Schwartz, thank you. And we're here today to talk about something that has been a really huge problem, and that is opioid addiction. And this is a disease that affects people of all ages and genders and backgrounds, and what we want to do is to encourage people to use all the resources that we have in the state. And you can visit our liveloud.org site or call 1-800-563-4086 anytime, 24 hours a day. Our governor has said that August 31st is Overdose Awareness Day in Connecticut, and our administration has done this because we do not want there to be a stigma on addiction. We need to recognize it as a disease, and we want to encourage people to get help. The good news is that we've seen the overdose mortality rate go down from 22 to 2021, but even one death is too much. So good things are happening, but we want to do more. We want to try to reach more people, encourage more people to get help, and it literally takes a village to do that. And so we have some very committed people around this table to try to help us get that message out. And before we start having a discussion about what we can all be doing in this community and in our state and at the national level to fight this disease, I'd like my co-moderator, Commissioner Nancy Navarrete, to say a couple words about the good work she's doing.
Thank you, Lieutenant Governor. Thank you for having me here today, and thank you for inviting me to co-chair. I'm Nancy Navarrete. I'm the Commissioner of the Department of Mental Health and Addiction Services. I want to thank all of our panelists and, of course, CCAR. We've been amazing partners for a couple of decades now, so we appreciate all the work that you do and your commitment to this cause, helping thousands of people across Connecticut. The great thing is, right, we're having this conversation today. Too many lives have been lost to this crisis, and tragically at this point, all of us have probably experienced a connection to this crisis. Losing a friend, a loved one, a neighbor. Any of us could probably share data dashboards, lots of statistics, lots of numbers, but that's really not where it's at. It's the fathers, the mothers, the sons, and the daughters that have been lost to this devastating disease. Really, this American generation has probably been affected like no other in our history. So we have a responsibility, I feel, to continue really the sense of urgency to find solutions and save lives. substance use disorder is treatable and recovery is possible. But every time I hear about another death, I can't help but really feel the weight of yet another person who has not had the opportunity to find recovery and has been cheated out of that opportunity. This roundtable is really a chance for us to talk about what we're doing as a community. We've come together to expand access to all kinds of treatment options across Connecticut. Demas alone has distributed over 30,000 naloxone kits and Narcan kits throughout Connecticut. And we know that hundreds of reversals are happening every single month. And that's what keeps us going. Hope that those folks live another day to get another chance to connect with a recovery coach or a path that works for them. We have built upon our prevention efforts to inform teachers and trusted adults about substance misuse, given tools to parents so they can have those conversations with their kids, no matter what the age, worked with pharmacists and prescribers to rethink treatment of pain, moved to harm reduction strategies to save lives, implemented campaigns to eliminate stigma, you'll hear us talk a lot about that today, and connect people to services. We have funded programs and recovery supports for special populations such as pregnant and parenting women and people that are involved with the criminal justice system, so whether that's diversion or re-entry. We've created new access points in underserved communities and churches, from mobile units with first responders to teach and engage people into recovery, and created spaces like this where people can have a safe space to explore connection and recovery. We're just so lucky in Connecticut that we have trusted leaders who believe in health and wellness and mental health and wellness. And as such, we have robust options for individuals and families. I'm optimistic that we can change the trajectory of these overdoses, and today we will highlight some of those efforts. So welcome and thank you.
Thank you.
Thank you, Commissioner, appreciate it. So what I'm gonna do now is I'm gonna introduce each of our panel members to just say a few words about who they are, and we're gonna start with our congressman, although everybody knows him.
Maybe not quite, but anyway, thank you, Lieutenant Governor and Commissioner, for organizing this and bringing people together. I mean, when you talk about issues like this, you know, I believe you can never over communicate. You know, I think it's really important for people to really, you know, be, you know, sharing, you know, information as frequently and robustly as possible, because that really is the only way I think you really get to the bottom of this. You know, the epidemic, the COVID epidemic, in some ways, I sort of felt kind of masked this problem for a couple of years, as all of the folks who were, you know, in the community know. The opioid overdose epidemic continued, and if anything, you know, maybe even picked up momentum. And so, you know, but now we're certainly at a place where, you know, that none of that colliding epidemic exists anymore, and, you know, hopefully we can really, again, redouble efforts at the local level. You know, CCAR, which I've, you know, been here numerous times before, back when I was a public defender, worked with some of the programs like Perception House. You know, there's just really always been a real strong commitment in this area by both professionals as well as volunteers, you know, to really participate in this. And but it's an evolving threat. It just constantly keeps changing. We were in New London the other day with the overdose action team, who was talking about again the xylazine, which is now the new adulterated, you know, version of the drugs that are out there right now, and it's just another sort of layer of complexity in terms of trying to, you know, figure out the right tactics and strategies. Even the White House recognized this a couple weeks ago by naming xylazine as an emerging threat under the existing CARA law, to really refocus again, you know, whether it's DEA or HHS or whatever, you know, to really you know, get on this, and it's sweeping the country. I mean, the numbers actually out west and down south are just frightening in terms of the prevalence of that. So again, thank you for organizing this, and look forward to, again, you know, learning something and hopefully sharing something in this conversation.
Excellent, thank
Thank
you.
you.
Thank you. Madam Deputy Commissioner.
Thank you.
Jody Terranova from the Department of Public Health. I have been at the department since the end of January. Before that, I was a pediatrician for almost 20 years, mostly in Hartford. I actually started my career during my training working with a lot of mothers in recovery, so this topic is really quite important to me. And seeing mothers with children, really that's their motivation to stay well, and I'm bringing a little bit of that work into the work I'm doing now at the department.
Thank you.
Thank you.
State Representative Susan Johnson.
Thank you so much for inviting me and having this is a very important issue for everybody. I think a couple of things that when I was the chair of public health a few years back, one of the things I learned was the fact that many of the people who are addicted, become addicted, had an injury. And the injury then the doctor gave them medication. And maybe they didn't give them the surgery they needed. They kept them in pain longer than they needed to be in pain. And we find that with workers' compensation and also with the insurance industry itself. So I see the insurance industry as one of the major causes of addiction because they're not providing the health care that needs to happen as quickly as it should happen. And it's something that we don't really focus on in the conversation. But I didn't have any idea until I was chair of public health. We had an event here in town at Eastern with the police and the public health department, and I still have the data, and I use it, my workers' compensation testimony when I work to try and change some of the things the delays in the workers' compensation program. But in any event, that is something that we even heard about when the settlement occurred with Attorney General Tom. And we have there a young woman now, but at the time had an injury in school, didn't get the treatment, ended up addicted, and went through her youth and her early adulthood with an addiction. So a lot of this could be fixed with better healthcare access and understanding when somebody is on the brink of becoming addicted. So those are the kinds of things, whether it's Medicaid, Medicare, because addiction occurs later in life as well, or under the workers' compensation program, fixing that program. In the state, we have some rules that need to be changed that I've been working on for several years that have limited access to health care by the insurance industry, and of course, regular health insurance as we know it right now. So I point the finger at the insurance industry, but also us. One of the other things I've been able to do is work with our police here. And we've created, they have this wonderful program called the Pride Coalition. And the Pride Coalition provides education to junior high and high school students about addiction, about drugs, about how the government works. They bring the students to the Capitol. And I've been able to actually create a scholarship fund for them. So when they graduate from that program and go on to post-secondary education, they'll have a little bit of money, not much, but a little bit of money to help them. So those are just a couple of the things that I've been working on.
Thank you so much for that. And the legislature has also taken steps to try to limit the amount of opioids that doctors can prescribe, because we also know that there was over prescribing going on for all kinds of things, from post-dental surgery or all kinds of other injuries and medical issues. Mayor DeVivo.
Well, I want to thank you for hosting this today and for all of you coming together. Wyndham, you look at it, these are all our neighbors. These are folks from outside our community that may come to our community for the first time because they're struggling with an addiction problem. And there's always, I'm trying to learn a lot here and listen a lot, because I think the more we learn helps our public safety folks, helps people at the hospital, so we provide them the resources that they need. I was glad to hear this really isn't a data dashboard. This is our families. These are our cousins, our brothers, our sisters, our neighbors. They're everybody that we know. And I'm sure there is no one in Connecticut that doesn't know someone that struggles with a problem. And this new drug, I just heard about it last Friday. Now it's like in the White House. So they're talking about it. They have better research than I would. Great. So, but thank you for doing this, and I'm looking forward to hear more and learn.
Great. And we're going to end with our CCAR hosts, Rebecca and John.
Sure. So good afternoon, everybody. My name is Rebecca. I am the Director of Advocacy for the Connecticut Community for Addiction Recovery. But I'm also a person in long-term recovery myself, and it's been over 25 years since the last time I used heroin. I share that openly with the hope that by doing so can help to reduce the stigma as well as to, inspire others that change is possible and that recovery is possible. And I'm thrilled to be here in Willimantic where, this is my home. I grew up in Columbia. I went to high school in Willimantic. I spent many years of in active addiction right here. But I also began my recovery in this town as well. So it's dear to my heart to be here and to, kind of talk about, improving the services for people here in this community. So thank you.
Hi, I'm John Schwartz. I'm the Recovery Center Manager here at the Winter Recovery Community Center. I'm also a man in long-term recovery. I haven't used since December 7, 2009. I'm also the co-chair of the Willimantic Opioid Task Force. And I just want to say that, I got to Willimantic in July of 2016, and I've never found any place more powerful to be than in a recovery community. I started at CCAR as a volunteer in 2014. I was encouraged to take training. And I just, like I said, when I got to Willimantic, I'm an addict. I wanted more. When I found CCAR, I just wanted more. I needed more. So, the degree of courage that people exhibit on a daily basis in this space in order to transform their own lives is absolutely remarkable, and it's a great honor to be here. So thank you, and thank you for being here.
Great.
Thank you.
Okay, so I'm going to use your expertise from DPH, Deputy Commissioner. And so before we begin this important discussion, I think we should set the table for everyone, so to speak, and take a look at the overall picture and where we are here in Connecticut in terms of overdoses.
Thank you, Commissioner. So, we are not in a great place in Connecticut. One of the things I like to do when I'm looking at a problem is to see, how do we compare with the rest of the country? A lot of this we were looking at with COVID, like, oh, we're doing great with our COVID vaccine rates, we're doing well with these things. With opioid overdoses, we rank the 14th highest state in the country. It's not a very, very good place to be. We know West Virginia is the worst, and Nebraska is actually the lowest. But Connecticut and a number of other New England states are way up there. And this is a problem that we're seeing across our state. The counties that have the highest number of deaths are New Haven and New London counties. Windham County actually in this last year of 2022 was the lowest. And you guys were the second highest a couple of years ago. So you're doing something right. You really decreased the number of deaths in this county. And so I'm really excited to hear a little bit more about what you've been doing and what's been working so that we can extend that across the state. We have on average 4 people die a day. So sometimes we give the larger numbers of how many a year, which I think, and especially again with COVID and hearing COVID deaths, sometimes those numbers just don't seem to mean a lot. But every single day, 4 people are dying in our state. We have at least 14 overdoses reported to our poison control center where we've been tracking the number of overdoses that emergency responders are attending to. So 10 people are making it, but 4 of them are not seeing their loved ones at the end of that day. And so that's work that we need to do. We know that 60% of overdoses are occurring in a residence, in a home, either the person's home or a friend's home, and that 87% of the fatal overdoses are occurring in the home. So it's really important as we talk about some of the interventions like naloxone, that family and friends have that readily available, because folks are dying in a home. They're not dying in public spaces. And so I think that was a really important thing that I learned recently, because I wasn't really thinking that folks were dying at home, and they really are. And if we look back over the last 10 years, the number of deaths in our state have risen 300%. And we know that because the amount of fentanyl in our drug supply has increased significantly, and I think we'll talk a little bit more about the dangers of fentanyl and why so many folks are dying from it. But that's really been one of the causes of the increased number of deaths. So I'll stop there because I know we have a lot to talk about, but just to give you that little bit of perspective and things to think about as we continue our conversation.
As we look at the data across the state, we really have noticed that the Northeast and the Northeast and the Northwest have done a very good job. They're smaller towns, and these task forces that you mentioned, maybe you could talk a little bit more about them. I think they've been very effective in bringing people together and creating some successes.
Well, Willimantic is, we have an embarrassment of riches in terms of resources, we really do. There's so many people who, and I think it was a result of those horrific articles in the Hartford paper back in the day that made everybody come set up shop, but the task forces are really tasked with bringing all the community partners together in order to make sure that no one falls through the cracks. Because there are a lot of services provided, but not everybody knows who offers what at which times for what. So in conjunction with all of our partners, and you mentioned Karen from Wyndham Pride, who's absolutely wonderful. She's on the executive committee as well. We managed to put together a comprehensive list of resources. We put together a packet of resource information that Emily, the social worker embedded in the Willimantic Police Department, is dropping off to people when she does follow-ups after an overdose. We have a great working relationship with all of our regional coaches and with the Wyndham ED, so that people are referred here. We actually have a great working relationship with Chief Hussey and Lieutenant Solak from the Willimantic Police Department, who also refer people to us on a regular basis if they can avoid having them incarcerated as opposed to offering them services. So we really just work to facilitate conversation between the stakeholders of the community in order to make sure that we're all aware of what we can provide for people in need.
I just want to add to that because I think that one of the things that we have to get back to is perception programs that was started way before anything in the paper, which was a misrepresentation of addiction. It was a misrepresentation of what really occurs here. And it was really a stunt that was pulled by the reporter to try and get an award. And she worked together with somebody who was putting a stunt together. So I wouldn't use that as an example as to why we have these riches here. Dr. Glasser put together a perception program. Dr. Glasser had been really very instrumental back in the 80s and 70s, working to put together programs to help people with addiction. And so it wasn't necessarily that at all. It was, I think that was a big minus actually for the town and for people with addiction. And I didn't see that as a help. So I just wanted to.
Well, thanks for clearing that up.
Very sensitive about that.
Apparently.
Yes,
Don't believe everything you read.
Thank you.
But she's 100% right, that's what happened
Yeah.
in that time period. But the perception programs in the houses that they went back to Passover, they worked, he started, and then, the other month, right?
Well,
Yeah,
Dr. Glasser, and
That's
then
right.
he was a champion for people. When he was getting his residency, he did it in the Native American tribal area in the Midwest with his wife Irene Glasser, who was a sociology professor at Eastern. And I actually had her for Soch back in the day. And then he helped create Generations as well. So he's really been a great innovator all throughout here. We have a lot of resources here nobody else has because of the work of Dr. Glasser. And
Yeah, but I think one thing that someone told me is that recovery's become more of our industry. Went from a mill town to a recovery community, and I'm proud of that. It's nothing to be ashamed of. That brought up to me by, actually, a pharmacist who opened up his legal marijuana store, recovery, sure. Your industry there, I was like, yeah, well, thanks. You moved to Columbia, but anyway, that didn't happen. But that didn't happen, so whatever, but it is,
we're open here.
but you do a lot for our community, and I appreciate all the work you do for the kids and the family. And Wyndham Pride, we struggle funding that every year. That we have to find funds. It was started with a federal fund, and eventually aged out. I guess you only get the money through WRCC. You only get the money for like 10 years, and there was quite a few discussions at the town council level, should we actually hire these folks, and pay them, and, cause Karen came from WRCC and then came to the town now. And fortunately, we prevailed, and now it's a program out of our new community center, so it is a very positive thing to have in our community, it's nothing to be afraid of. You're great, pay taxes right here, the building has jobs, and it's a good thing to have here.
And I can attest to, growing up in this area, perception programs was always here and always there to support people that needed it. And, I have, there's a trend where these smaller behavioral health organizations are merging with larger ones. And my fear is that, we're gonna lose these smaller providers that are so integral in, they know the community, they know the community, they've been here. So I never want to lose sight of the fact that these smaller organizations are just so important in the communities that, that they provide that help to.
I think that's an excellent point, because you raised an issue that I have a big concern about when you see what happened to Wyndham Hospital when Harvard Health took it over, and they are a big monopoly in healthcare in Connecticut now, along with Yale and Haven. So now we've got the monopolization of this hospital care and all the subsidiaries that they have, along with taking it on the doctors. So we have a real problem in terms of how do you write policy.
We could have a whole nother roundtable
A
on
week's worth.
healthcare access,
Yeah.
Representative Johnson, so we're gonna put that one on the list.
Thank you so much, Lieutenant Governor, right way.
Absolutely, cause I so agree with you.
Move on to the
But
mobile.
I have a question for, the commissioner, and that is, we had been seeing a very disturbing trend, up until 2021, where every year the number of confirmed, overdose deaths were increasing. And now, hopefully we've turned a corner and we have started to see a decrease, and it looks like, for 2022, there was a 4.4% decrease. And, tell us what are the factors that are contributing to that decrease in the mortality rate? And I'm glad we just had the sort of community-based discussion before you sort of talk about statewide what's happening.
Sure, so, we're cautiously optimistic, right? We're coming out of COVID, people were isolated, I think people were reporting more depression, more anxiety, feeling disconnected. Places like this weren't as accessible as people were kind of hunkered down in their spaces. So glad that spaces like this are open again, because fentanyl is so incredibly lethal. So, we're crossing our fingers. We have flooded the state with all kinds of interventions, from harm reduction, prevention, recovery, supports and treatment, special populations, as I mentioned, pregnant and parenting women, folks involved in the criminal justice system. But it takes such a small amount of fentanyl to affect somebody, depress their respiration, have them overdose, and now with xylazine, which is a tranquilizer that veterinarians use, that is, it's not an opioid, so it depresses the respiratory system even further. You administer Narcan, which reverses the effects of opioids, does not reverse the effect of the tranquilizer. So you may give a dose of Narcan, the person is still sedated, that's why we have to make sure to call 911, do rescue breathing, because this is a very deadly combination. So those rates, were crossing our fingers that we're doing the right thing, and you mentioned how the Northeast was so dramatically hit by this crisis and overprescribing, and the result of so many people that have been addicted to opioids. This is positive for Connecticut. because some of our neighbors have not seen this turnaround and have seen an increase in use post-COVID. So we're keeping our fingers crossed that we're ahead of the curve on that. I don't know, Deputy Commissioner, if you wanted to add anything to that about the lethality of fentanyl, xylazine, and of course stigma, which which only hurts us if people cannot raise their hand and say, I need help. Right? If they're embarrassed to do that, then these resources are not tapped into.
No, I think just to give you a perspective on the potency of fentanyl, so it's 50 times more potent than heroin and 100 times more potent than morphine. So it takes a very small amount to cause a very dangerous effect.
So Commissioner Navarrete, can you just briefly talk about whether there are certain demographic groups that are disproportionately affected in our state? What are the groups that seem most vulnerable at this moment?
Well, initially this crisis really seemed to affect young white men. And so at the time, early 2000s, actually, I was working in a detox and working for a big behavioral health care organization. And that was a change. We were seeing a lot of 20-year-olds, white males coming into treatment. Over time, that's changed slightly. So now we're seeing a big uptick in non-Hispanic Black males and Hispanic males. So that is really rising in terms of a demographic that's being affected. And this may or may not be connected also to the fact that the drug supply is so contaminated. So it doesn't matter if the drug that you're going to buy is an opioid or cocaine or a pill in pill form, you are buying fentanyl. And so it's affecting people in underserved communities at this point in time. And I know you have the statistics from EPH as well.
Yeah, the only other demographic piece I'd add would be that age has really shifted. So it's a little bit older now, 35 to 44 is the age group that we're seeing, which you wouldn't necessarily think that little bit older age group. And then we have been partnering with the medical examiner's office. So we have a staff member embedded there that's been interviewing families. We've just started up a fatality review board to get more information about the folks who pass away and if there are any similarities. So we see that like housing instability is a factor. We see that a significant number of people have been connected to services or have been in recovery at some point, and those who have recently relapsed are at a higher risk of overdosing. So we have some of that other demographic data that's helping us to target our actions and our plans going forward.
So now I'm just gonna, and some of you have already touched on this, but I'm gonna ask what our federal, state, and municipal governments are doing. So Congressman, if we could start with you, and then we'll go to the state.
Sure. So, again, that 1 year shift is hopefully, knock on wood, a trend. And but I think still, from a national perspective, this is still a really serious problem that you hear from members, from red districts, blue districts, every corner of the country, as I mentioned earlier. And I mean, to the extent that it's actually caused a downward pressure on life expectancy in this country, you can just sort of stop there. I mean, the US used to be sort of like at the top of the list in terms of life expectancy. We aren't right now. And COVID obviously was partly involved, but that sort of slowdown occurred pre-COVID. And there's no question that the opioid crisis was a factor there, and still is, in terms of really cutting short people's how long they live and how long they enjoy their lives. And so what I would say is that it's an all of the above strategy right now. And if I had to describe what the administration's perspective is on this, both supply side and demand side, starting with the demand side, which I think is fundamentally how we have to fix this problem once and for all. We need to continue to fully fund the Substance Abuse and Mental Health Services Administration and HHS SAMHSA, which is really still the workhorse of federal block grants that come into departments like the commissioners that fund a lot of the great work that she was describing earlier. We had a great omnibus budget that just passed and was signed into law in December, at a 15% increase for SAMHSA in terms of these efforts. And, that's gonna make its way down to states with their allocations. in
And
terms
our
of-
own Miriam Delphin Whitman
Right.
is leading
That's
that
correct.
federal department, so
Yes.
go Jenny.
So that's all good, and also, the drug-free communities, program, Tom, you mentioned that, which is that seed money for the drug-free communities, it's 5-year increments, that you get one extension. I don't know why we cut that program off after 10 years, but nonetheless, whether it's Putnam Pride, Wyndham Pride, Summers, Connecticut actually just got a drug-free community grant, which you don't think of as a community that, sort of fits the profile, what you would think is, but, there was, huge grassroots support in the town to sort of fund that. And then there's also basically community project funding, which we got, some funding for Reliance Healthcare down in Norwich for more recovery coaches in last year's budget, and then I think Chris Murphy was able to secure some funding for, Child and Family Services in southeastern Connecticut, again, focused on substance abuse. So, we're dealing this week, because I fly down tomorrow morning, the new speaker is coming out with his budget plan, which would just decimate non-defense spending. It's just, it's like, it almost seems preposterous. It is in terms of, but the fact is, he's got a gavel and he's got a majority in the House there, but they're talking about basically at least a 22% cut in last year's funding levels for non-defense, could go as high as 38%. And that's what, I'm flying back to. So it's nice to get some good karma here, with some people before I head down there. And we'll just have to sort of see how that all sort of shakes out. But on the supply side, because we get the calls in our office from people in our district, and they're legitimately upset about the fact that this stuff is coming in, illegally across the border, and what is being done, to sort of stop that. So, this is something that we track very closely, with DEA and, the Customs and Border Patrol, because the southern border is definitely where I think the bulk of this stuff is coming through. One thing that we have heard loud and clear from the professionals, the people who are actually down there, and they are, stopping and seizing record numbers of this stuff. But as you point out, it is such a small, concentrated volume that, that you can make a lot of money off of. That it's just, this is really tough stuff. And so, the president just released funding for, much more scanning technology, because this stuff is coming by vehicle. The sort of urban myth that it's like, migrants coming over with, kids and minors, or, walking, who've been hiking or getting brought. It is vehicles. This is very, well-organized, drug traffickers who are bringing this stuff over. And again, you can hide a small amount in a truck or a car, and if you can get by, that's a good day, in terms of how much money you're gonna make. So the scanning technology, which has really been pretty, if any of you have ever been to a border stop down there, I've been to Nogales, Arizona. It's almost like the George Washington Bridge in terms of the volume of stuff that's coming through there. So, how do you deal with that without just sort of seizing up, just normal people or normal business or, commerce coming across the bridge there? That's where the scanners, I think, are so essential, because these things are actually very sophisticated and can detect even relatively small amounts that otherwise would be totally missed. And those are being installed in places like Nogales and, the California border, where the stuff is coming through. And so, I think it's important to remind people, because there is this sort of narrative that the stuff is just coming over and no one's doing anything about it, no one cares. And the fact is that there's a lot of resources and effort that's being put in to really get on top of this problem. Xylazine, again, is another sort of complexity here, because it isn't a drug. It's not regulated by, you know, it's not a scheduled, substance, it's an animal tranquilizer, and so, you know, I mean, all I can say is that, as I said, the White House Office of Drug Policy just designated it as an emerging threat, on April 12th. And that really, again, gets the agency sort of focused in terms of just, we've gotta come up with like, a different kind of strategy in terms of just how we do this. Harm reduction obviously helps at the sort of, you know, consumer level, but that's still, it requires somebody who wants to go out and get the strips and all that stuff and test for it, and you can't rely on that, I don't think, you know, to really get your hands on it. So, hopefully we're gonna continue with consistent funding levels, so the good work, you know, that's coming through the department, you know, continues. And then, as I said, it's an all of the above approach in terms of getting both the demand side and the supply side, to get, you know, our arms around this.
Rep. Johnson, do you have anything you wanna add to, I know you mentioned some legislative initiatives and some community initiatives.
Right, and certainly Pride Coalition is something that is an excellent thing locally and is able to work with the Pride Coalition, you know, regularly, with only a small break with COVID. But also, one of the pieces of legislation we have this year is to fund Narcan for the school systems and make sure people have access, promoting the idea of Narcan in the home, so that, because most of the, as you mentioned, the problems with death because of overdoses occurs in the home. So that's the sort of thing that we're looking at. I think that would like to be able to continue to promote the idea of what the Pride Coalition does and extend that to the local schools. One other thing that I did when I was working with the Pride Coalition to create the scholarships was we also made it part of a chance for the students that participate to use it as part of their capstone project as they graduate, so that they'd be able to utilize the information that they learned in the Pride Coalition events during the summertime as part of what they're getting for academic credit. So we're able to work with the school system and do that as well. So I think it's really important to make sure people understand behavioral health issues, mental health issues, and what happens when injuries occur, and how these things can actually creep up on people. They don't even realize maybe initially that they're becoming addicted to something, and then there they are, and then, oh, by the way, the doctor says, well, you can't have any more, and then they're in pain, and how they get through that issue, and then they're in such excruciating pain. Some people commit suicide. We have that kind of a problem, or they seek some other way of addressing that injury and that pain. So it's a multi-pronged approach that I've been as I said, I've been working on with workers' comp and other insurance policies, but it's something that we need to take a look at, and I think training kids from the beginning about the problems with any type of alcohol, drugs, whatever it is that changes your consciousness. It has the potential to be addictive, and we need to focus on how that sort of thing is. And I just also want to say, I'm really thankful to be here today because it's part of what I'm doing for the national group of legislators as well, working on behavioral health issues. So this is really quite informative. So really
Thank you. Thank you. So taking my cue from what everyone
Yes.
really has mentioned here, prevention is another prong of DMIS. So you think of us as the treatment state agency, but we are responsible for prevention across the lifespan, children and adults in the behavioral health space. And so we've partnered with DPH. We have a long-running campaign called Change the Script, which you may have heard of, and really an award-winning, it has gotten awards, campaign Live Loud, which is living life with opioid use disorder. Two very important steps in getting that education out to people so that they know what resources are available. Also working with school-aged kids and having curricula available for teachers should they choose to access it. Schools are independently run, so each superintendent gets to make some of those decisions, but it's packaged so that they can grab it if they need it. We've put together packages of materials for parents. How do I have this conversation with my school-age kid? How do I have this conversation with my high school kid? And having some of those courageous conversations and giving parents some of those tools to be able to do that. We've expanded that was one of the first things that we did was expanded access to medication-assisted treatment, which includes buprenorphine and methadone. Connecticut, we're very lucky that we have a very robust infrastructure. We probably have 40 methadone clinics. We've embedded recovery support specialists in methadone clinics because we really believe that, again, multiple pathways to recovery. People need to talk to someone, they need that heart-to-heart conversation, need to be able to connect with somebody that has walked walked that walk so that they can see it's possible. We have recovery supports in emergency departments. We have them connected to DOC. We've done a lot of partnership with Department of Correction. In the early days, we learned that probably 50% of the people that were overdosing had a connection to the criminal justice system. So, and that was even before this rise in fentanyl. So people are vulnerable, they come out, they hadn't used for a while, then they use, and of course the results are deadly. So working with DOC to bring up methadone clinics and Suboxone while folks are still incarcerated, and then transitioning them to community-based providers so we don't have that vulnerability when people leave the criminal justice system.
So Commissioner, I'm noticing that we have maybe 12 minutes left, and I would love it if we could focus on sort of CCAR, what they're doing and what insights they have for the policymakers in this room.
I would too, so Rebecca and
Sure. So I really want to highlight not just our coaching programs, which are wonderful, but also our centers as well. And I want to thank the congressman because we were the recipient of some congressionally directed spending. And we will, in the next year or so, we plan to open 3 new recovery community centers. And one, we're looking at the Norwich, New London, Groton area. So, another center in this part of the state is going to, help provide that wraparound services for people. But I'd like to kind of throw it over to one of our recovery coaches, Will, down at the end, because he does work in the hospital emergency departments out in the eastern part of the state. So, Will, can you talk a little bit about, some of the challenges and what people are experiencing here?
Yeah, absolutely. Hi, my name's Will. I'm a recovery coach in the emergency department, like she was just saying. I've been with CCAR for about a year, and I've come across a lot of obstacles for people, and a lot of them are unique to each individual recovery that I see. But there are many that I would say are problematic for the demographic as a whole. I would say a lot of people, I believe you were saying that the age of people we're seeing is increasing. I've seen a lot of people who are retirement age and beyond, and talking about getting hooked on opiates at that age, and what can I do? I need some help. And
Is it because they were taking opioids for hip replacement, or I don't know, knee
Right,
and that stuff?
exactly. They started out with a prescription for it, and then eventually became hooked, and then no longer able to get the prescription because your injury is healed. You don't need this anymore, and they find themselves using fentanyl or heroin, but heroin is fentanyl now. These people are, more times than not, they have Medicare as insurance. And I don't know how many times I have to, tell somebody, I'm sorry, we're not able to get you the help you need today because you have the wrong insurance. And that's heartbreaking. And all they just, also,
So wait, are you saying that if you're on Medicare and you have this problem, Medicare won't help you?
Residential. What's that?
typically for residential care,
Very limited.
is very limited.
Options are
Right.
very
So,
limited.
so there has been some, I'm sure Commissioner can speak to your 1115 waiver and how that's kind of allowed some treatment providers to bill Medicare and to accept more Medicare patients, but we're not seeing that really translate across the 9 Medicaid withdrawal management facilities that are in the state of Connecticut.
Yes, we've tried to pick up the tab for that because we know access for people with Medicare is limited. They did include, Medicare now pays for methadone, but some of the residential treatments, they do not, and so we've included. So if you ever have a problem, please call us.
Absolutely, yeah. For ambulatory services with Medicare, there's a little bit more ease of access. But for some individuals who have, pretty challenging social determinants of health and are also Medicare recipients or Medicare members, residential care is extremely challenging to connect them to.
Well, let me just add something to that, or question how that works, because one of the things that happens when you're Medicare eligible, but also maybe Medicaid eligible, so Medicare would deny the coverage, and then it would be covered by the 1115 waiver and the Medicaid. So not to confuse Medicare with Medicaid, but initially Medicare will be the primary payer, and Medicaid is the payer of last resort. So that would be how that would work. So I'm just wondering if in your process, try to clarify for that.
Absolutely. So when we see insurance types of Medicare and Medicaid combined, it's a different situation. But when we're seeing different types of managed Medicare, for instance, Blue Cross Blue Shield, and we're hearing treatment providers refuse care because they're not getting reimbursed by insurance companies to pick up the tab for Medicare recipients.
That's half the Medicare population now.
That's
who's
right.
on those plans.
That's right.
Yeah.
And that older demographic is something you really have to
Yeah,
keep an
no,
eye on.
that's
right?
really interesting.
As the admin for the telephone recovery support program, I see the new consents coming in and the dates of birth are getting further and further back. I'm working with people who are older than me at this point on a
Right.
regular
Yeah,
basis, which is shocking to me.
But that's because I think some of the Medicare programs aren't as, let's say, they're cutting back on care, cutting back on nursing home placements, cutting back on a number of things that back when I did the work with Medicare, they provided the coverage for these things. You had a longer stay in a nursing home. Now, in the state of Connecticut, we want to make sure people aren't placed in nursing homes. We want them to do the home care. So what are they? They're home alone with maybe some support, but maybe not the kind of home care that they really need, and maybe not the support that they need. And by the way, back in '97, when they did the home care services capitated payment plan under the Medicare home care program, that cost shifted everything to the states. And so once that was cost shifted to the states, then what do? Well, we have to do, money follows the person in Connecticut, so that we can get that whole system set up for Connecticut so that we have a lower cost. So it's been quite a process in terms of how all this works. And so we, of course, people don't want to ever be in a nursing facility. On the other hand, the nursing facility is a good spot to be. If you have that hip replacement and you need to get the physical therapy so you don't make mistakes when you're trying to do this stuff on your own, at home alone. So it's, I won't blabber on anymore, but.
And no, these are not easy things. So CCAR, any more barriers to people seeing treatment? You've talked about barriers that some of the older folks that you have are seeing. Any others that our policymakers should be aware of? Yeah. 5 minutes. Or more, we'll give you our cell phones.
So my name's Kevin Schuler, I'm the program manager of CCAR's emergency department program. We're currently in 30 hospitals across the state. We operate from 8 a.m. to midnight, 365 days a year. So collectively.
God bless you.
Thank you. And so a little bit about my history is I'm a person who lived with opioid use disorder for a long time. My recovery was non-linear. It took many naloxone reversals. It took many treatment episodes. It took hospitalizations and intubation and dialysis. I'll spare you a lot of the consequences of my addiction, but where the hope was in the tangible evidence of people in recovery not giving up on me and having that really courageous heart-to-heart conversation. And so that's why I was compelled to kind of get involved in recovery support. So maybe not necessarily the treatment end, but certainly in that lived experience that comes from another person who has walked the walk and who can speak to the hope and the challenges associated with recovery. And we have to normalize recovery because of the stigma not only associated with addiction, is also with recovery. So what I would see when I would enter the emergency department previous to this program's existence would be stabilized, a naloxone reversal, a quick EKG, and stabilized and kind of pushed out the door, maybe with a piece of paper with some detoxes that I could reach out to. And when I heard about the program of recovery coaches going into the hospital and just being living proof that recovery is possible, it very, very much touched me. So I became a recovery coach after some volunteerism in the center, and I saw the culture here at CCAR. And I transitioned to the program manager. So in 30 hospitals, each month we're seeing about 500 folks. And we're seeing overdoses, and we're seeing the most prevalent substance is always alcohol at about 64%. We're seeing about 74% of Medicaid members are the people that we serve. And about 10% are Medicare recipients as well. And so, and then we see a block of individuals who are uninsured. And CCAR, thankfully, to the flexibility of funding that we're provided, we don't turn anybody away. We don't bill any insurance. We believe that recovery is not conditional, and we will support anybody. And so Will stays connected with the folks that he meets in the emergency department each day. And his call list may be sometimes 40 plus people. Today he had a light day. He had 11 people that he called. But those are people that he established a connection with, that he tried to help connect to care. The barriers, to speak to the barriers, what we need to see is more, we have a medication that can almost immediately mitigate the withdrawal symptoms and give a person some hope. And we've removed the X waiver for providers to have a barrier of prescribing this life-saving medication of buprenorphine, Suboxone.
Okay.
Yeah. And we're seeing some hesitancy and some ambivalence on the end of ED doctors to actually prescribe this medication due to lack of education or maybe stigma, whatever it may be. I won't speculate. But we, as recovery coaches, have the ability to find a brick and mortar facility for them to transition to. But we need to allow a person to find some peace and some relief from their withdrawal symptoms and see and feel what life can look like removed from the substance. And so we're seeing barriers there. There is a coalition and champions in the healthcare systems that are really speaking to this. Some healthcare systems do it better than others, but we would love to see it embraced a little bit more across the state. Additional barriers with that would probably be, I mean, there's always barriers with just the timing of bed availability. I mean, we see some people at 11 p.m. at night and they're being discharged from the hospital and there's no beds available, and it's due to staffing in treatment centers and a lot of challenges across the state with that. So bed availability barriers at the time and need willingness from a healthcare perspective to give a life-saving medication and potentially give a person an opportunity to stay in a safe space until they can transition to the next level of care. Will be great to see. The naloxone saturation initiative by Demas has been phenomenal. Obviously, naloxone gave me the ability to be here today, so I'm a little bit biased towards it. But,
We're happy to.
yeah, but we try to provide that whenever we can and advocate for it to be included in discharge plans as well. So the barriers are vast, but there's the support and the determination and the vigor of people like Will and recovery support specialists alike, and is really, there's a lot of strength in numbers, and so we just need to continue to put people on the front lines and to support each other. And I would like to see more collaboration across organizations and systems. Like, there is no kind of propriety over a person's recoveries, right? So that's what I have to say. I'll get off the soapbox now, but thank you.
Oh my
Thank
goodness,
you.
well, that was perfect, that was perfect timing. CCAR, thank you so much for having us, our colleagues in local, state, and federal government. Thank you for joining us, we really appreciate it, and call on any of us to help with whatever we can, and we look forward to continuing collaboration.
Thank you.
Thank you.
Thank you.